Mai, haere mai. Welcome to our webinar today. Let's open with our karakia. Tēnei te ara o Ranginui e tuaki nei. Tēnei te ara o Papatuanuku e takoto nei. Tēnei te ara o Rangi Rawa o Papa e takoto nei. Kia raro te tapu wai o tānei ki raro, tēnei te pō, nau mai te ao. Karangatia te au e piri, karangatia ko tānei e piri e tata. Whakamaua kia tīna, tēnā. Haumie, huie, tāi kie. Kia ora koutou, ko whaiora, ko Ella Miftari Cullen toko ingoa, he uri ahau no te arawa, nai tū hoi, nā te whakaue ara peinia hoki. Welcome everyone, hello. My name is Ella Miftari Cullen. I am one of the directors at Te Hiringa Mahara. I look after the wellbeing system leadership team, data and insights, and was responsible for the publication that we're here to discuss today. So we are here today, the webinar you've joined is to discuss achieving equitable wellbeing outcomes for tāngata whaiora. What we know, what needs to change. So welcome everybody. On the panel today, just really quickly, we've got Laura Ross. She's our resident principal advisor wellbeing. She's the lead author on the report, a passionate advocate for wellbeing, child and youth mental health, with at least a decade in the health sector. Kia ora, Laura. We've also got Professor Te Kani Kingi on the panel today. I don't know how much of an introduction he needs, but he is our mental health guru in Aotearoa, expert in a myriad of things, Māori mental health, public health researcher, has many, many accolades, health service delivery. Ngā mihi nui, welcome to you, Te Kani. And our final panelist is Alex L. Amani. He is on our board for Te Hiringa Mahara. He's our favourite board member. Just joking. But today, Alex brings lived experience of mental health, addiction, justice, and social services. Alex works in the sector and clinical practice as an addictions practitioner. So welcome to you all. And I'm just going to quickly hand it over to the rākau over to Katie, just to go through a little bit of our housekeeping today. Kia ora, Katie.
Kia ora, no mai haere mai e te whānau. Thank you so much for joining our webinar. It is awesome to see you all introducing yourselves in the chat, and even more special to see some really friendly and familiar names in there. So just a little bit of housekeeping. I'll keep this brief. I won't be sending out an emergency alert that woke most of us up at 6:30 in the morning. So hope you're doing okay after the early start. The way that this works is we'll hear some talks from our amazing panelists, and then towards the end we do have a Q&A session. So if you could please put any questions into the Q&A part of Zoom. So if you look on your Zoom, it's sort of on like the right hand side. I do have to do this, so excuse me. If you could look and click on the Q&A, it's like a little speech box with a question mark. Put your questions in there. You can use the chat function to introduce yourselves and say kia ora to everybody, but questions Q&A. This is being recorded, but we have muted everybody and we've turned your videos off. So if you're sitting in bed and watching this webinar, kei te pai, no dramas, we can't see that. And a link will be sent to everyone who has participated today or enrolled but not able to make it. At the end of the webinar, there will be a really short survey just for asking for your feedback. So say really nice things about that. We would appreciate that so much. Yes, I think that's us. I'm going to hand over to our first speaker, Laura Ross.
Kia ora. Stephen, have you got some slides for me? Perfect. Well, tēnā koutou katoa. I'm Laura Ross from the wellbeing team here at Te Hiringa Mahara. I led our assessment of wellbeing for people who interacted with mental health and addiction services, and I'm really excited to share our findings with you today. I'm going to talk about why we did this work, how we did it, what we found, and what we want to see happen next. Firstly, why? Next slide, please. So Te Hiringa Mahara is responsible for assessing population, mental health and wellbeing outcomes. We assess outcomes using our He Ara Oranga wellbeing outcomes framework. This framework has 54 indicators drawn from national social surveys and other national data sources. We've looked at wellbeing outcomes before. We looked at a total population level in 2021 and for young people and Pacifica people in 2024. Last year, we sought to shift our focus to people with lived experience of distress and addiction. We know wellbeing outcomes are distributed inequitably across population groups, and we have some evidence that people experiencing distress or addiction have experienced inequity in aspects of their wellbeing compared to others. We wanted to understand more about the outcomes that are most important to those with lived experience. So how? Next slide. What we wanted to do was compare outcomes for people who do and do not have lived experience of distress and addiction using the indicators from our He Ara Oranga framework, which are drawn from the government's integrated data infrastructure, the IDI. However, that turned out not to be possible with the current data in the IDI because we don't have a way of identifying who does and does not have lived experience. Not everyone interacts with services when they're dealing with distress or addiction. So we used a second best option of comparing wellbeing outcomes for people who had and had not interacted with health services for a mental health and addiction reason. We're not the first to do this. We're really grateful to the Social Investment Agency, to Professor Nick Bowden and colleagues, to Amanda Eng and colleagues for sharing their work and their insights. So we created 3 cohorts and we looked at wellbeing outcomes across 20 indicators from three surveys, and these were the General Social Survey, the Household Economic Survey, and the Te Kupenga Survey. So next slide, please. So for each of the surveys, we split the respondents into 3 groups. We looked at specialist services, and that's people who interacted with specialist mental health and addiction services within the 5 years before their survey interview. This one's based on linkages to the primed data set and was about 5% of survey respondents. We also looked at a wider group, any services, and this included the specialist services group, but adds in people who had a mental health and addiction related hospitalisation and people who had a mental health or addiction related pharmaceutical dispensing, a medication, within the 5 years before their survey interview. This was about 20% of survey respondents. Lastly, for comparison, the third cohort was no services. That's the remainder of people who didn't meet the criteria to be in the services group and was about 80% of respondents. There's a bit more nuance in how these cohorts were constructed, and if you're interested, you're really welcome to contact us. We can provide our methodology, our code. Cool. And next slide. So now that we had our groups for comparison, we looked at 20 wellbeing indicators to understand how wellbeing differed for different groups. We found across most indicators a similar pattern of inequity. Over the next slides, I'll cover the 6 main findings. I'd like to thank here our lived experience data reference group, shout out if you're online, who supported us to prioritise the indicators we focused on and to interpret the data. It's also really important to be aware that these findings are a view of the status of wellbeing. We didn't set out to measure outcomes achieved from using specific mental health and addiction services, and this work doesn't speak to the performance of specific services. So overall, we found greater barriers to wellbeing. So in comparison to people who didn't use mental health and addiction services, people who interacted with services were less likely to have good life satisfaction, mental well-being, family well-being, or feel like the things they did were worthwhile. People who interacted with services were less likely to have good self-rated health. Next slide, please. Material well-being was a key barrier. So people who interacted with services were less likely to have the income that meets their needs and therefore the material things they need to support their good well-being. Almost half of households with 1 or more people who interacted with specialist services did not have enough income to meet everyday needs. Next slide. So we know that social cohesion is critical, social connectedness is critical for mental well-being, but we found lesser access to that connection. People who interacted with services were less likely to have social connections that support them in their times of need and were more than twice as likely to experience loneliness. Next slide. And we'll send the slides out, and all of this information is in our publication, so you can access all of that too. So this slide shows that there are challenges relating to belonging and inclusivity. People who interacted with services experienced higher rates of discrimination of any type and were much less trusting compared to others. 1/3 of people who interacted with specialist services and 1/4 of people who interacted with any services at all reported experiencing any type of discrimination in the last year. Next slide, please. Nearly there, whānau. Our Hiara Oranga Wellbeing Outcomes Framework is dual-framed, with a Tāu Māori perspective alongside a shared perspective. In our analysis, we looked at 8 Tāu Māori wellbeing measures for Māori who interacted with services compared to Māori who didn't. We looked at engagement in identity and culture, and we found similar patterns between those who interacted with services and those who didn't. We found that Māori who interacted with services were equally engaged in their identity and culture and were just as likely to feel hope for the future. Māori who interacted with services were highly likely to know their iwi and equally likely to be able to speak te reo Māori and to consider taha whaiora as important to them. There was no difference in the proportion of Māori who thought it was important to be involved in things to do with Māori culture between the groups. Last finding slide, please. So we also looked at whānau wellbeing, which was poorer among Māori who interacted with services. Māori who interacted with services were less likely to have someone to support them, and they were less likely to say their whānau was doing well compared to Māori who didn't interact with services. We know, however, that whānau is really a critical avenue for Māori mental health and wellbeing. Next slide. So we know that addressing the determinants of wellbeing is complex, and it requires all of us to work together. These findings show that more needs to be done within and beyond the mental health and addiction system to address the inequities and wellbeing outcomes of people who experience mental distress and addiction. The Hiara Oranga inquiry in 2018 called for strategic leadership from central government on wellbeing, prevention, and tackling social determinants that impact on multiple outcomes. We want to see commitment to addressing the structural drivers of inequity for people with lived experience of distress or addiction. And we look to government for coordinated cross-agency leadership, as well as approaches to solving the root causes of inequity. We will continue to hold and reflect the voices of lived experience in all that we do to advocate for better wellbeing outcomes. I'd like to again thank the Lived Experience Data Reference Group and the other lived experience leaders we spoke to for this project, the Social Investment Agency, the researchers that shared their work, and the team at Te Hiringa Mahara. We're really keen for others to build on what we've started here, and we know we've only just scratched the surface of what this data can tell us. So our infographics available for download on our website, and our code, our methodology, and the data, including demographic breakdowns, is available on request. Ngā mihi nui. Thank you for your time today. And it's my absolute pleasure to hand over to Te Kāne Kingi.
Bueno, Laura, tēnā koe, nei rā no taku mihi ki a koe mō tō kōrero o kauhau hei whakamārama ki a ngai tātou, ngā hua o tō rangahau. Ela, hoki mō tō karakia, hei tūwhera ai tā tātou hui huinga, hi rungi te hui topa nei. Alex, tēnā koe e hoa, koutou mā, o reira, he mihi poto tēnei ki a koutou katoa. Well, I was told that I had about 10 minutes, so I've avoided speaking too long in my mihi, but really just wanted to thank you all for joining this webinar and for Te Hiringa Mahara for inviting me along and for giving me the opportunity to, I guess, reflect on this research report. My name's Te Kāne Kingi. a bit of a background in mental health, mainly in the research area. Currently reside in a little place called Poroporo, just out of Whakatane. And looking online is probably only the people, you can see some people from Opotiki and Kawerau, maybe the only people online that know where Poroporo is. But that's where I hail from, and once again, incredible opportunity and privilege to be able to speak today. I'll try and keep it as brief as, well, I will keep it relatively brief in terms of my reflections, and in that way provide more opportunities for Alex to kōrero. And likewise, if there are any questions, be more than happy to, I guess, to take those. Having read the report, I just wanted to make one point that I think it's incredibly valuable, and having worked in the mental health sector for research primarily for a long time now, I do know that there's not a lot of timely, focused or robust health research, mental health research within New Zealand, especially those which utilise statistical or empirical data, which this study does. Just as a brief example, New Zealand's, strangely, only ever had one psychiatric epidemiology study undertaken. That was completed in 2006. Now, the implications of that epidemiological study were and have been incredibly profound in terms of guiding mental health policy and strategy. But that was almost 2 decades ago. And while there's likely to be a child and youth psychiatric epidemiology study rolled out shortly, it does give you some indication of the lack of, I guess, empirical mental health research that's been undertaken in New Zealand. And again, highlights the value of this particular study and this research report. But part of the reason why we haven't undertaken many sort of quantitative studies in the past is due to cost and complexity. But as you've heard previously, the study wisely utilises existing and administrative data. It's reliable, accurate, and cheap. The most expensive part of any program of research tends to be data collection. So I thought it was a very, very wise path to follow. We're utilising existing data, and just wanted to commend the team. There's no perfect methodology, but I thought that the methodology that they constructed and deployed as part of this program of research was exceptional. So tēnā koutou. And I also like the fact that they were looking at some really novel and complex associations and relationships, not simply focusing on illness or disease or the sort of typical items that researchers tend to want to examine, but looking at broader societal relationships and connections, those types of things that are quite apart from service delivery, can have a more profound impact on people's lives and their well-being. So I thought that was great as well, taking a different approach. Best thing about the report and the research, in my mind at least, was that they deliberately sought to answer the most important question. And that question, again, in my mind, is the so what question. How can we utilise this information to make things better for our people? So not simply producing research for research's sake, but to inform policy, strategy, and service delivery. So I hope everyone takes the opportunity to utilise this information and in ways that supports their own mahi. Data from these types of studies can or typically difficult to interpret. One of the things that you need to remember, I need to remember, is not to overreach, but to interpret things or the data in ways that are accurate and meaningful. And as we've heard, it does reliably reveal a number of key insights and highlights, especially for those, and as mentioned, those that engage with specialist mental health and addiction services. The thing that stuck out for me was the fact that for those individuals, life satisfaction is not just slightly, but considerably lower than for those that don't access these services. That's something to think about. Think about as to why it's considerably lower, putting aside what we mean by life satisfaction, or how that's assessed. The simple fact that it's lower, and in my mind, significantly lower, that's something to reflect upon in terms of those that access services. Levels of family wellbeing, as you'll see from the report, also lower, and also more likely to experience high levels of discrimination, loneliness, and just struggles to keep up with the cost of living. Hopefully I didn't cut out too quickly there. And there are related studies that highlight similar issues and challenges amongst people that access mental health services, including the fact that life expectancy tends to be lower. And this is revealed in many other studies, as well as the points that have been raised in the study around lower life satisfaction. Now, these are all significant issues. A broader concern, again, however, and from a research perspective, is that without accurate and contemporary epidemiological data, it makes it difficult for us to completely understand the complexity and the extent of these issues, and they're not well understood. So the report has highlighted a whole suite of challenges which disproportionately impact on those that access mental health services. It would be great for the future to really, I guess, drill more deeply into how these issues and challenges have emerged, and again, what the potential solutions might be. Now, I know some of the people online, I can see you'd have all the solutions, and I might highlight a couple of those shortly as well, because again, it's one thing highlighting what the problems are, but I think there's greater opportunities in terms of identifying solutions so that can actually make a change. Also, what it showed to me, and I'll finish up shortly. I know my 10 minutes is probably by now, but I did pick up on the point that mental ill health can be largely indiscriminate in terms of its reach, and this was also shown revealed within Te Reo. The nature, the severity and the impact of these mental health problems can vary across populations, as we know, but it has a reach into all groups and all populations. As well, there are vastly more people who suffer from mental health concerns that seek care. Unfortunately, and for those that do, access is also likely to be compromised. Access to care likely to be compromised, be late, and the outcomes suboptimal. And within New Zealand, at least, probably similar to other countries, comorbid and complex problems are likewise typically the rule rather than the exception in terms of mental health and mental ill health. Now, that said, the broad implications of this research highlights the fact that the impacts of mental ill health are not and should not simply be confined to clinical settings, but that they are likely to impact on the lives of people in more elaborate and profound ways. For example, how they navigate life in societal institutions, how they might be perceived by others, or even interact with them. Moreover, the stresses and strains of life that we all experience are oftentimes more amplified amongst those who interact with mental health services. However, and as highlighted previously, the value, I think, of this research, and I can't stress this enough, is that it doesn't simply locate challenges or concerns, but it does contemplate potential solutions. And in this regard, I think the research highlighted the need to support initiatives which in turn support the ability of people to flourish, and I mean to truly flourish within their communities. These initiatives that help people flourish, I don't think they're the sole responsibility of the mental health sector, but they are just as likely to have a more positive and profound impact on people's well-being. A more holistic approach is an approach that Māori have been advocating for some time. Further still, and if we do look at a more holistic approach to mental health and well-being, and we promote that, I don't think that it should simply be confined to socioeconomic, environmental, or ecological factors or supports, but likewise appreciate and value the importance of culture and identity for Māori especially, and as a driver of health and whaiora. And I think that was really great to see as well within this research, strengthening the relationship in an empirical way between culture and identity and mental health and well-being, and the ability of people to really flourish. Māori and some of the people online I can see have been promoting that idea for a long time now. So tēnei no taku mihi kia koutou. But it's also great to see it coming through in this research, this report, and this review. Whaiora, tērā tāku, oti taku kōrero, whaiora, e kene pēr māku hei tuku te rākau kōrero ki a koe. Alex, tēnā koe, tēnā koutou.
Kia ora mātua, tēnā koutou. Ko Alex Tokuingoa. My name's Alex, one of the board members at the Mental Health and Wellbeing Commission, Te Hiringa Mahara. Just before I start, I'd like to acknowledge a moment's silence for people with lived experience who might currently be in treatment or living in recovery or might not be feeling 100%. So this is for you if you do have lived experience. Otherwise, if you don't, please acknowledge somebody who you know who does. So we'll just take a moment's silence now. Kia ora, ka pai. Thank you. So just to do a brief intro, who am I? Ko whaiora. I'm an AOD counsellor, working in private practice at the moment, part-time, also a PhD student, and that's basically my full occupation. I also have a few other little roles in education and research around the sector, and obviously I've been a member of the board here since 2021. So I am part of the, we just saw that presentation from Laura, 5% of the people had used specialist services. I'm part of that 5%, not that I participated in this survey, but just acknowledging if I had, I would have been in that 5% who had used specialist mental health services in the past 5 years. And that's the name, specialist mental health services, is what we're calling any services that go beyond your GP. And so, yeah, I've been asked today to share a little bit about my lived experience perspective on wellbeing. And so I've got lived experience of addiction and living experience of accessing the services. I've had to navigate the wellbeing system process for myself and tried to help a few of my peers to do it too. Meaning, you know, basically sometimes we have to address our own determinants of wellbeing. And coming into the mental health services, as a person with lived experience, I thought that, you know, all areas of my life satisfaction would be enhanced, but it was mainly just treating my mental health stuff. So there was a whole other system out there, the wellbeing system, which for some of us, like me, I required more than just a medical assessment and a prescription, which is what the mental health services offered me. And I learned this again firsthand presenting back at the services recently. You know, I knew the drill. I knew I'd get some meds, and I also knew there'd still be something missing. And I knew I wasn't going to achieve good well-being all around just by taking medication. And I needed something else to address all my needs. And you know, I just want to share a little bit of my story, just to show how diverse people's needs can be. And I just want to acknowledge too that there'll be other people with lived experience with their own experiences too. And so mine is just one of many and might be similar to others. So when I first emerged out of a period of not feeling too great, I was searching for something in life, and I had attracted a whole bunch of labels to me, which were starting to form my identity. Those labels were things like drug addict, criminal, suicidal, psychotic, stuff like that. And I'd started to live that because I thought that that's what I was. And I look back now, and it was what I really needed was a new identity. So I was searching for it. I didn't know where it was. I even tried to enroll in the army, and they didn't want me. I tried enrolling in university a few times and got denied. And then one university gave me a chance, and I wasn't feeling great when I first started going there, but emerging out and becoming a student gave me a new identity, which suddenly gave me a new social group, a new purpose to be. It gave me a career, an income, that helped me have somewhere to live, and that helped me afford good diet and good food. and I could actually address those type of needs that I had. So even though I was searching for something to keep me well when I presented at the mental health services, and they did give me medication and it did help stabilize me, it was something that you can't prescribe that actually helped me kick me into a new gear. And so and I'm definitely not suggesting that everybody goes out and enrolls in university, but I'm suggesting that everybody's got something like that can help shift their well-being into a new gear. And you might have to find it yourself. Otherwise, there's a whole well-being support system out there as well that can help you. So yeah, just mainly emphasizing that well-being is broader than our medical needs being treated, and that it's usually treated outside of the specialist services. Which brings me to my next point. I wanted to shine a light on an example of what I think is going well. So at the Commission, we like to shine a light on things that are going well. Sometimes we probably would do it more formally through a report and some consultation. So I'm just going to do a very ad hoc and informal shining the light today on what's going well. So the team at Hiringa Mahara, we usually have our board meetings at the office, like most organizations. We branched out recently, and we had an offsite meeting at the Wellington City Mission. And arriving at the Wellington City Mission, I was, as I'm not from Wellington, it's hard for me to find my way everywhere. And so I was probably a little bit under a bit of stress arriving. And as I walked in, there was this instant energy that I felt as I walked into the building that uplifted me, an uplifting energy, a positive energy, an energy that made me not worry what had just been going on in my mind. And then as I went upstairs, I noticed this bustling cafe downstairs with a lot of people all doing their own thing. And yeah, so I'd really like to shine a light on Wellington City Mission today because of what I experienced there. And basically, it was the well-being place to go. If you needed support with your well-being and you walked in there, I can pretty much guarantee you'll walk out with enhanced well-being from one of the many different things they do. I really can't do it justice here today to list all the things because I know I'll forget something. But it was diverse. It was from food to being able to do your own laundry, and to giving people a bed, to income, employment, medical, legal support. There was even dental treatment available. And, as I say, there was much more than that. So it was incredible for me to see Wellington City Mission doing all this, all in the one place. And the level of respect that was just amongst everybody there was, really positive. So, an important part of well-being as well as community. And walking in there, I really felt a sense of community, even though it was my first time there. I felt like I'm part of this community, and that's an incredible thing. It's something you can't prescribe. So Wellington City Mission, for example, could be what study was for me. Yeah, I do mention the dental work that they provide as one of the many things, because I can totally relate to that. Just to share a tiny other piece of my story was that I had poor dental hygiene. I was part of my lived experience of addiction was that I was addicted to meth on and off for about 10 years. And complications from that caused a lot of dental hygiene issues for me. I had black and rotten teeth. And I thought that was my lot in life. Basically, I thought I had to live with that. And when I emerged and went to university and was about to join the workforce, I really lacked confidence because I thought I looked too much like a meth user face. I had to go out and try and seek dental support. It was very difficult. I wasn't able to. But then when I started working, there was finally a point in my life where if I'd swiped my FBOS card at the dentist reception, it would have actually accepted. So I decided to embark in trying to get my dental stuff fixed, which exhausting all the WINS stuff and exhausting all the stuff as a student, spending a small fortune of my own money. I got it done. And they're not perfect now, but I can tell you that it was one very small thing that gave me confidence to get out there. It gave me self-esteem, and it definitely boosted my hope, which is really important for well-being. It's like this two-way relationship, which is really what I saw at the City Mission. You help one area, and the other areas of well-being start to do well too. And that's why the Wellington City Mission was sort of like this one-stop shop, where they could have helped someone, even with something as small as dental treatment, which is poignant to me. And that could have led to enhanced well-being in other areas. So I think probably getting to the end of my time, so I'll just finish on a summary that well-being is more important. Well, I think well-being is more important for people with lived experience, because as the reports highlighted, some of us will live shorter lives, and it's important that we have that better well-being for that shorter time we're around. And just lastly, I had to represent back at services recently, and they were largely the same as they were when I first went there about 20 years ago. And we were expecting the system to be transformed, and it doesn't seem like it's happened yet, which is disappointing. But I think back to before we talked about transformation, and consumers basically, as far as I knew and myself, were asking basically just for a service that was there for us when we needed it, that worked for us, that helped us, and that was accessible for us. We didn't know that that was transformation. We thought the system was already further along than that, but it turns out maybe that is transformation. So maybe that is something we're still waiting for, because yeah, as of recently, my experience was very much the same. So yeah, thank you very much for listening, and I'll hand it back over now to Ella.
Might jump over to me. Oh, look, thank you so much, Alex. I hope you can see in your screen all of the hearts, all of the applause hands. The chat is going off with just so much aroha to you. So thank you so much. Big thank you to our whole panel, to Laura, to Kangi, to Alex, for your mahi in this space, for your passion, your love, for your experience. It just, yeah, I'm stoked to have you on this, and it's an honor to be able to work with you all in some way. So this is incredible. We have heaps of questions, heaps of questions, and we have maybe about 15 minutes left. So I've sort of been going through them all and theming them up. I did want to start with one question. This is probably more for Laura and Ella. It's about what surprised you with this data, with this research. Some of the comments, and some people were saying, well, this isn't really surprising, but was there anything that surprised you?
Yeah, thanks, Katie, and also, yeah, thanks so much to Kani and Alex for beautiful kōrero. That was just really special. So thank you so much. But what surprised me? What surprised us? I think that's a really good question. So I was surprised about how pervasive the inequity was and how it spanned so many domains. I think, as came up on the Q&A, it was expected that we'd see poorer mental well-being, and we did. But I think it was the reach across income, across social cohesion, across whānau, the wider impact of a person's lived experience. So a couple of other things that jumped out at me here is how we found a similar pattern, not quite the same magnitude, but a similar pattern between people who interacted with any services and who interacted with specialist services. And so it's worth remembering that the any services group is 20%. That's 1 in 5 people. So it's people we all know. It's not this marginalized small group that are having these really poor outcomes. It's many of us, me included. And so I think just to realize how broad this stretches and sort of the population of Aotearoa was something that kind of, that gave me pause. A little finding in here that also surprised me was sense of belonging. And sense of belonging was a measure that was in the 2021 General Social Survey for the first time, as quite a cool measure. And what we found was it was the same across these groups. So despite this poorer well-being, poorer mental well-being, poorer physical, self-rated health, poorer access to fresh fruit and vegetables, discrimination, loneliness, all of these things, yet sense of belonging was still really high, and same across groups. So yeah, kia ora.
Kia ora. I think it's important as well to celebrate, those areas where we can see some good, such as sense of belonging, because I mean, it's heartbreaking that we expected this from the research. It's not, like you're saying, it impacts so many of us, and it's just not fair and it's not right. I think it's what makes this work so important. So coming to that is another question that's been asked quite a lot within the Q&A is, what do we do with this research? What do? We know something needs to change. I did want to throw this over to Te Kani first and then over to Alex, because I'd love to hear your perspectives from what do we do next?
Very good. Well, again, another great question, and I guess from my perspective, and probably more so now that I'm getting a bit more grayer, I'm always eager to ensure that research serves a purpose and is not simply undertaken to generate information. I think that would be an unfortunate waste. And quite often research identifies what the issues and challenges are. Now that's one part of the equation in terms of the utilisation of research and information to identify where the pressure points and where the challenges are. But I think with this research report in particular, there's a number of ways in which the information generated from it can be interpreted. And if I was involved in service delivery or supporting people with mental health needs, I would use this information to really put forward the position that in order to contribute to a person's health and well-being, to enable them to flourish, we can't simply look at clinical investments. And as Alex touched on in his presentation as well, there's a lot more that contributes to a person's health and well-being, and that's what this research highlights to a great deal. It highlights the point that if we're looking to develop policies and strategies for mental health, they shouldn't simply be confined to service delivery or the mental health sector, and that we should at least contemplate the idea that mental health strategies for mental health and well-being extend across all sectors, and it's the responsibilities of those sectors to think about how their policies and strategies impact on the mental health and well-being of their population. And I really can't, I guess, emphasize that point enough in terms of what this report can contribute to and its utilisation. And I know, look, and not picking on you, Alex, but I really enjoyed your kōrero on your conversation, because it just solidified in my mind that there's lots of things that contribute to your mental health and well-being. Treatment can tend to be the focus of the health sector, but there's a big difference between treatment and care and well-being. And again, what this report highlighted to me was really identifying all those components of well-being, albeit to some extent challenges and issues, but it really, I guess, reconfirmed what a lot of us have thought. And I take point taken with some of the comments, the things that we already know. They are things that we already know when we're working in the mental health sector. We need to ensure that others external to our sector and what we know, we need to emphasise towards them that they have responsibilities for the mental health of our people as well. Anyway, hopefully that's responded somewhat to the question.
Beautifully. Yep, you're getting a lot of love in the chat, and I've seen the hearts and the clapping hands coming up as well. Perfect. Alex, I'd love to hear what you've got to say as well.
Kia ora. Yeah, look, and one thing I'd mention is why I shined a light on Wellington City Mission is basically more services like that. I think it's a very consumer orientated service. I think if you locked some consumers in a room and asked them to come up with a wellbeing service, it would look similar to Wellington City Mission. I don't say that lightly, because there's a lot of talk in the sector about any door's the right door, and I say from the sector and from the system, not so much from people with lived experience, because we when walking into doors, we already thought this was the right door, and we didn't know that the system would be set up with all these labyrinth of doors that we had to walk through. Why would someone set up a system for us to have a difficulty accessing? So the way the Wellington City Mission, where they make it just so easy to access, while you're there, why not do this? Why not do that? Why not do that? So making things, easy to access and all in one place is one thing we do next, I believe, not the only thing. Probably more investment, because now we've acknowledged that our needs are higher, our needs are greater, so then that should follow with greater investment in our needs. And accepting to some degree, some parts of the sector, including the wellbeing sector, might not fully transform as we might have accepted. So or it might take longer. It might still transform, but it might just take longer than we thought. So if it does, then how can we be pragmatic for now? And I think in terms of that, we've done enough inquiries. There's stuff we need to do from reports from the inquiries from the 90s and the early 2000s. We've had enough reviews and reports and inquiries. One thing we do need to do, though, I think, is a survey. We need to do another population level mental health survey. So yeah, and basically following up with the stuff from the inquiry as well. So yeah.
Too much hui, not enough doughy, right? I mean, I've worked in the public sector for a long time, and I hear that every second day. It's time to take action, and I think it's really valuable to have this information, but we produce this information knowing that it needs to go to some good. And I mean, that's collectively up to all of us as government, as society, to do something with it. So we've got a few more minutes. There is one more question that I did want to ask, because it has been brought up a lot about what comes next. There's particularly been quite a lot of reference to housing, and whether our work will be moving more into that space. I mean, what's Te Hiringa Mahara doing next in this space? Ella, I know you don't want me to throw it over to you. Unfortunately, it's coming to you.
No, that's all good. Yeah, kia ora, thanks for the question. Look, we do have a role as a commission to continue the focus in this space. We've got, we will continue monitoring outcomes for tāngata whaiora for people who use and interact with mental health and addiction services. So that will keep going. We do have, we're going to dive a bit deeper in the next kind of 3 to 4 years and really look at some of those key determinants of some of these outcomes. And we are doing a piece of, well, I don't want to speak ahead of time, but we're definitely looking at potentially housing or other some of the determinants that we saw in here, and looking at that at a system level. So what does that look like outside of the mental health and addiction sector, and how are people sort of traveling within particular for housing through the system. So I think we've definitely got a role to keep this conversation up. So we'll continue monitoring and assessing. And yeah, it's a good question, because we're definitely going a little bit deeper next year, which is the way to go. Yeah, kia ora. Thanks for the question.
My pleasure. We are coming towards the end of it, and we do just have a couple of closing messages. But just want to say thank you again to our panel. You are all wonderful. It's been an honour, a privilege to hear from you today. Thank you for letting me throw over to questions. I know some of them are really big and we all want to say, what do we do now? I think you've given some really tangible examples and just want to mihi as well to this research. And echoing back to our moment of silence before, you know, behind all of this data are people, are whānau, are communities. This is why we're here. This is what we're all doing it for. We just want things to get better. So Ella, I might throw over to you to talk about a very exciting opportunity coming up later on this year.
Kia ora. Thanks, Katie. And again, just acknowledging our awesome panel today. Thank you very much. Yeah, just thank you for sharing your experience, your knowledge, and all that you bring. It was just an awesome panel. You guys have covered so much. I was going to kind of do some closing remarks, but yeah, just in terms of hearing from all of you, the data is always going to give us the information needs to take action. And we have to, I mean, when you asked me, Katie, before, was there anything that surprised you? Sadly, no. It's the surprising thing is the lack of sustained action, which I think there are a few opportunities to kind of point it to strategy. So I do just want to plug the mental health and wellbeing strategy will be out for public consultation very, very soon. And I just encourage everyone to participate in that process. We've got this assessment available on our website as an input. We've also got a system performance monitoring report. All the links I think are getting put up in the chat, where we share kind of our vision for a better mental health and addiction system in terms of the 6 shifts that we think need to be made to kind of achieve these outcomes that we want to see and you know, turn the dial on some of these outcomes. So yeah, just really wanted to plug that. The other final thing and note I wanted to make, we have our first Haura Hinenaro, there it is, He Ara Tūroa conference. So we're co-hosting this conference for the first time. It's up in Tamaki Makaurau. We're going to bring together a whole bunch of people from the sector and the system to talk about crisis and the crisis response. So don't miss out. Program's out now. Get in fast. There's limited places, so just encourage everyone to check that out. So yeah, look, that's probably enough from me. I just wanted to say another ngā mihi kia koutou to everybody, and thank you, Katie, Stephen, everybody who makes these webinars go so smoothly and well. Thank you. And I'm just going to close with our karakia whakamutinga. Pau hihiri, pau rarama, te aho I roto, marama I roto, tēnā te pau, ko te pau ka eke, nā te pau o ēnei kōrero. Ka mā a te ariki, ka mā a te tauira. Kia puta ki te whai au, ki te ao marama. Hui te ora, hui te marama. Haumi e, hui e, tā e ki e. Kia ora koutou.